The treatment options for a patient that presents with a HER2 positive breast cancer really focus on the timing of surgery and I think the timing of adjuvant therapy. The guidelines really support an approach of chemotherapy given with HER2 targeted therapy, both in the adjuvant and the neoadjuvant setting. So those are all going to be features of her disease. I think the component is really looking at the timing and the sequencing. So for this patient who has a 2-centimeter tumor and lymph node positive disease, the best recommendation for this patient would be to approach neoadjuvant chemotherapy with her dual HER2 targeted therapy followed by surgery. Now, discussing the specific parameters of chemotherapy gives some options for patients. There can be an anthracycline-based regimen followed by a taxane, at which time concurrently is the standard of doing the dual HER2 therapy with a weekly taxane. I'm much more of a fan of the taxane platinum program, so the docetaxel carboplatin, Herceptin, and Perjeta. I think it's really well tolerated. The issues, I think, of cardiotoxicity are a little different between the regimens. They're very effective regimens, both of them, but I do think the risk of cardiotoxicity and symptomatic congestive heart failure is slightly higher in the anthracycline-based regimens. I also look at whether the patient has a left-sided breast cancer and whether there's going to be the role of radiation therapy, and that certainly would dissuade me from the consideration of an anthracycline-based regimen. But largely, I practice with the docetaxel carboplatin dual HER2 neoadjuvant regimen. When I talk to the patients about treatment options, I do talk about how the standard was just single agent HER2 targeted therapy with chemotherapy. And then we looked at the data now that has evolved, the addition of pertuzumab to Herceptin in the neoadjuvant therapy and what the advantages of that is to the patient. So we have a long discussion because the therapy can come with a little bit more side effects, but the advantages are increasing the chance that there's no disease at the time of surgery. And we know from our meta-analysis that the patients who have no disease at the time of surgery have the best disease-free and overall survival. And so for those patients, I really talk about the Perjeta. It does have an increased risk of diarrhea for patients, and we talk about what does that look like concurrently with chemotherapy, since some of the chemotherapy agents can also result in diarrhea, and sometimes it's hard to distinguish. We talk about the prophylactic medications that we're going to really try to get on board if the patient does experience that toxicity. But I think the advantages of the dual HER2 therapy that have now made it a standard of care for a HER2 positive patient in the neoadjuvant setting, that we're going to really try hard to commit to that program. I have occasionally had to drop pertuzumab in a patient after dose modifying the chemotherapy. And then I do revisit with that patient and pertuzumab in the adjuvant setting in the absence of chemotherapy.